Dear colleagues, we're happy to present you the report which topic is Peculiarities of Ocular Prosthetics in Microthalima. Microthalima is a severe intrauterine abnormality of the visual analyzer. It is characterized by the decrease in the eyeball size by more than 1-2 millimeters comparing with from the normal, and functional inferiority of the visual organ. The eyeball has an abnormal structure. The global prevalence of microthalima varies between 2.4 and 3.5 per 10,000 births. Congenital microthalima is diagnosed in 2.4% to 11.2% of all blind children. In Scotland, the prevalence of microthalima and anophthalma is 19 per 100,000. In California, the prevalence of unilateral and bilateral anophthalma reaches 0.18 and 0.22 cases per 10,000 births, respectively. In Hawaii, the prevalence is 2.21 per 10,000 births. The Laboratory of Ocular Prosthetics in St. Petersburg reported that the prevalence of congenital microthalma is not lower than 0.18 per 10,000 births. Congenital microthalma can be associated with exogenous and endogenous fractures. Genetic fractures have the most important role in the development of microthalma. 50% to 75% of severe ocular disorders are believed to be hereditary. Congenital microthalma is often caused by degenerative and inflammatory processes. Some viruses, including rubella virus, cytomegalovirus, influenza virus, parainfluenza virus, and Coxsackie virus, exert a pronounced teratogenic effect. The main risk factors for congenital microthalma are maternal age above 40 years, multiple births, low birth weight, and low gestational age. Doctors usually fail to identify the main factors that trigger the development of this disorder. Congenital anophthalma and microthalma can develop independently or as a part of some syndrome. Pediatrician medical examination is required in order to find out concomitant somatic pathology, genetics in the case of syndromic conditions. The success of ophthalmic prosthetics is impossible without close cooperation of an ophthalmic surgeon, an eye prosthetist, an ophthalmologist, and a psychologist. While providing prosthesis for a child, an important point is the parent's participation. The condition of the prosthetic child cavity, care for the prosthesis and eye cavity, timely treatment for the purpose of the prosthesis replacing, and accordingly the indicators of the prosthetics in the future mostly depend on them. Of 42 children 1 month to 16 years old with congenital ocular disorders who were followed at the Laboratory of Ocular Prosthetics in St. Petersburg, 47 had unilateral microthalma, 5 had bilateral microthalma. Medical diagnostics included external examination of the eye socket, palpebral fissure and eyelids, the assessment of the conjunctival fornic state and the parameters of the conjunctival cavity. Both the reduced and paired eyes were examined with a mandatory assessment of visual functions. Electrophysiological studies, B-scan, CT, MRI. Ocular prosthetics is aimed to ensure proper development of the facial skeleton and to stimulate soft tissues and orbital bones by increasing the size of prosthesis and therefore expanding the conjunctival cavity using stepwise prosthetics. Ocular prosthetics in children have some specific characteristics associated with physiologic growth of orbit, eyelids, eyeball, and whole face. 90% of the eye socket growth is completed by 5 years. Prosthetics in the case of microthalma. The optimal duration of primary prosthetics depends on the length and the anterior posterior segment of the reduced eyeball at birth. Knowing size and the growth features of the eyeball in the first year of life, it is possible to predict the result of prosthetics and, importantly, the frequency of replacement of the prosthesis during this period. If the value of the eyeball axis is less than 7.5 millimeters, prosthetics is performed starting from the age of 1 month. In the case of the eyeball axis more than 7.5 millimeters, no later than the age of 4 months of the child's life. In microthalma, eye prostheses of the increasing size are used by the method of step-by-step prosthetics. These can be both conformers and the eye prostheses themselves. But since the replacement of prostheses should be carried out quite often, in the first 3-4 months from the child's birth, most often we used individually made conformers. This slide demonstrates you the prosthetics results of a child suffering from microthalma with standard and individual eye prosthesis. It is impossible to install prosthesis of complex shape in the cases of patients with microthalma. Such a prosthesis is not only sedentary but also exerts pressure on the reduced eyeball. Therefore, a prosthesis of the correct shape was made in the laboratory. At the same time, the palpebral fissure on the right acquired a natural shape. In the case of congenital microthalma, only individual eye prosthetics are optimal. It is impossible to use standard ready-made eye prostheses in order to compensate all the necessary parameters of the cavity. The eye prosthesis is a foreign body, therefore, during the primary prosthetics of the microthalma, a gradual adaptation within 14 days is required. On the first day, the time of the eye prosthesis wearing is 15 minutes. On the second day, the time of the eye prosthesis wearing is 30 minutes. Gradually, it is possible to increase the time of the eye prosthesis wearing to 3 hours a day by the end of the week. By the end of the second week, the eye prosthesis should be worn all day long. As for night's sleep, the prosthesis is removed. During the period of adaptation to the eye prosthesis, patients suffering from microphthalmia require the appointment of an antiseptic and reparative drug. You can see the framed photo on the slide. It is the result of an inadequate prosthetics. During the medical examination, we figured out a discrepancy between the parameters of the cavity and the eye prosthesis. Stretching of the eyelid tissues with an excessively large prosthesis. As a result, sagging of the lower eyelid, asymmetric opening of the palpebral fissure. A new individual plastic eye prosthesis was manufactured in the laboratory. The result of prosthetics is affected by the severity of the eyeball hypoplasia, the length of the palpebral fissure at birth, as well as the anatomical condition of the eyelids. Prosthetics is to be started as early as possible, depending on the severity of the eyeball hypoplasia. The slide shows step-by-step prosthetics with the individual eye prosthesis. In the case of bilateral microthalma, prosthetics clinically looks like an ophthalmia. According to the MRI data, these are rudiments up to 8 mm with parietal cysts. Step-by-step individual prosthetics was performed. Different forms of eye prosthesis were made in order to achieve a stable result. This slide demonstrates the result of timely eye prosthetics made by individual patients of increasing magnitude. While looking down, the upper eyelid is symmetrical with the upper eyelid of the paired eye. Late initial application for prosthetics at the age of 6 years. We noted the shortening of the conjunctival fornix. The patient came across great difficulties in adapting to an ocular prosthesis. Microthalma on the right side. Macrocornea coloboma of the choroid and optic disc. In order to accurately assess the size of reduced eye, an ultrasound examination is necessary. Therefore, it should contain 2 sizes of eyeballs, sagittal size and frontal size. With this microthalma degree, eye prostheses are not indicated. The ultrasound in dynamics is recommended as well. Sometimes ophthalmic surgeons resort to conthectomy in order to increase the length of the palpebral fissure. The external conthectomy leads to deformation of the ocular fissure and loss of the possibility of its prosthetics. On this slide, we can see that the outer edge of the prosthesis lies on the skin, outside the conjunctival fornix. Only an experienced ocularist can make prosthesis. A photo of an eye prosthesis with a defect is presented. Not only prosthesis with microcracks or prosthesis with poor surface treatment, but also prostheses that do not correspond to the desired size can cause inflammation in the reduced eyeball. Summary. The timing of primary ocular prosthetics is of fundamental importance for the symmetrical development of soft tissues and the facial skeleton. If the value of the eyeball axis is less than 7.5 millimeters, prosthetics is performed starting from the first month of the child's life. The prosthetics of children with Microthana is to be carried out only with an individual ocular prosthesis. In order to achieve a good cosmetic result, it is necessary to use the method of stepwise expansion of the cavity with mandatory consideration of the ocular prosthesis material. In the case of the eyeball severe hypoplasia, if it is possible to perform prosthetics if there is no proper result from conservative treatment, step-by-step surgical treatment with an individual approach to each patient is necessary. Thank you for